Hi everyone, this is the ParaPodcast team. We are here again, back with another exciting episode. As usual, I have the usual suspects, Tulani Sibanda, Elias Thomas. You know, one thing that is always fascinating is that you guys never know that we record in totally different locations. Elias is in New Zealand, Tulani is in Qatar, and our guest today is in Canada. It's always fascinating to organize times, but this time around, our guest just gave us a time that was likely to work. We tried once and then it works. So today we're talking about something that is very fascinating. Before I tell you who the guest is, I'm sure you can see him on the screen, maybe. He's a very interesting person. We met a while ago. It's 2015. I think it was the first time working outside of the country for me. And I met him there. Very gentle guy, very nice, teaching, I think, ACLS and stuff like that, at a company that we're working for. And I didn't know that he was studying, but I knew that there was a lot of research that he was doing also in the area in the Middle East. I'll say he had a funny accent. I know that he also said I had a funny accent too. I think for me, whenever you move outside of the country, you start meeting people here. So there are white people who speak like this. And then, yeah, it was fascinating. So we have Associate Professor Alan Batt. He is in Canada. He is very much involved in what they call community paramedicine. I'm going to ask him to tell us what he believes community paramedicine is. But to our viewers that are not familiar with what is happening now, we have a paramedic that has a primary degree. So primary degree is your first degree that you have, and then you go and work in the industry, and then you decide that now you want to change and do something else and focus in a specific area. So in other countries, you would do ICP, which is intensive care paramedic. Others, you will go to university and study community paramedicine. I think in other countries, there's been a new emergence of this thing called community paramedicine. But in this research that Dr. or Associate Professor Alan has happened, that he has done, there is evidence that this has been there for a long time. Right. Do you want to greet us, Alan?
Yeah, thanks, Malusi. Yeah, thanks for the invite, guys. This is it's nice to talk to people about the work that you're doing as a researcher and to try and meet new audiences and spread the good news kind of thing. So yeah, it's good to be here. I guess the community paramedicine stuff for me, I moved to Canada in 2013, I think it was. And community paramedicine was already pretty established here. It was starting to roll out in a much more organized fashion across the country. You have some evidence published from the early 2000s in Nova Scotia, for example, leading on to some additional evidence from the maritime area to Ontario, and then eventually across the country, all kind of around that early 2000s into the 2010s kind of time frame. And really, it's about, I think, acknowledging the fact that paramedics do a bit more than what we perhaps teach them to do. If you look at the paramedic curriculum in most countries, it's largely based on that 1970s Department of Transport curriculum in the US, which was paramedics go to motor vehicle collisions. They deal with trauma. And I know I'm speaking to people who have experience in systems that still have fairly high levels of trauma in, South Africa and Middle East and stuff. But that in a lot of countries, the role has kind of evolved from being the person who goes out to traumatic incidents to being the first point of access to the healthcare system. And I think community paramedicine is a reflection of that. And it has evolved, and there's no such thing as, I don't think there's such a thing as a singular definition of community paramedicine. It kind of gets implemented in different ways across the globe. Brendan Shannon and colleagues did a definition, a study to come up with a definition of what a community paramedic was. and it really focused on that piece of being, person-centered care in a diverse kind of range of contexts. And I think that's the important thing, is that this can look different depending on where it gets implemented. That could be primary care, or it could be health promotion. It could be in a clinic-based setting. There's a whole load of different things that community paramedicine is. I think the biggest thing really is that now that we've kind of matured a bit more in community paramedicine, we're acknowledging that it's moving, or needs to move more towards being an integrated care piece, so that it's not just paramedic services spinning up community paramedic programs themselves, but that they're working with other services, health and social care services in their communities, to basically provide that full kind of wraparound care that people need, rather than what we think they need. And so that's what some of the work that I know we're gonna chat about in a minute comes up in the community paramedic needs assessment tool, for example, is around this, like, let's stop deciding what people need from their healthcare service and start actually engaging them in the design of that.
Well, I heard you mention two people, Brendan and Shannon. Are they South African? Is it some?
No, Brendan Shannon is he's in Monash. He's an associate professor in the same department as me. So he led that definition of community paramedicine, and actually a bunch of community paramedic work around, like, we did a review on community paramedicine a few years ago, and we did a study that looked into the kind of the barriers and the opportunities when you're implementing community paramedic programs, and Brendan led a lot of that work as part of his PhD.
Okay, I think I've seen some of that work. I think you also mentioned it, that you mentioned it in the paper that we're going to talk about shortly. Right, in terms of in other countries, there's something that they call extended care paramedic. I think there's a question like that. In terms of Australia, there's something like that. What do you think is the difference between the two?
Depending on the flavor of ECP that you implement, very little. I would say that, like, ECPs started in the UK a long time ago, probably 20 plus years now. And it was really, that intent at the time was to bring emergency department skills to the road. So it was extended care paramedics in the UK had the ability to, prescribe, not prescribe antibiotics, but they could work on things that were related a bit more to the kind of emergency department view. So they could send people for x-rays, they could do some casting, they could do suturing, that type of stuff. That evolved into the point where they got prescribing rights, and the extended care paramedic kind of terminology in the UK is still used here and there, but it's largely evolved into that specialist and then advanced paramedic type terminology. I know that extended care paramedics in Australia, if you look at the definitions of how some of those systems are using ECPs and what they consider an ECP to be, it is what we would in North America probably call community paramedicine. And so, again, because you have these different flavors of implementation, I don't think there is such a thing as a definition of an extended care paramedic, in the same way that, like, we do have a working definition of what community paramedicine is, but it does get implemented differently. Like, could you come up with a description of what the scope of practice from a clinical skill set is for a community paramedic? That would be quite difficult to do that in a way that would work for everybody, because some places are doing, point of care testing, other places aren't. Some places are allowing for prescribing in jurisdictions that allow that, other places aren't. Some places are doing, like I said, some of those extended emergency department type skills with suturing and casting and stuff, and rural clinics in particular. Other places aren't doing that, so that it's very difficult to pin down some of this stuff, which makes it very difficult as someone who's researching the space. But also, I wouldn't change that. I think that's how it should be. I think that community paramedicine models in particular need to meet the needs of the communities that they're in, and they should probably all look slightly different, because not every community will have the same needs. And so I think depending again on the definition that you use for an extended care paramedic and the type of skill set you give them and the type of calls you're getting them to do, then I think extended care paramedic and community paramedic are very closely aligned, and you could probably in some cases swap the terminology.
While
no, go ahead first, Elias. No, you can go ahead.
No, Now, I think just since we're chatting on the paradigm and sort of the skill sets and so forth for community paramedics, do you think as paramedics that are working in the community, do you think we sort of like stepping into the environment of nurses? And do you think, it's kind of like, what are you doing and who are you and, who's supervising who and, I don't know, from your experience, what's been it like?
Yeah, I look. I think this is a common thing that happens worldwide. That there is definitely a perspective of role creep, I guess, and scope creep with some of these community-based roles for paramedics that um, nurses in certain settings can get the impression that paramedics are there to replace them. I guess there's kind of two pieces to that. One is, especially in Canada, we are in a nursing shortage. Like it's a fact. So we cannot hire nurses to replace nurses after they retire or leave for other reasons. And so a lot of the time, the choice is between reducing the ability to deliver health services or changing the uniform, I guess, of the person who is providing care. So at a certain point, it's not about who is delivering the care; it's the fact that care is being delivered, that there is a health service at all. And so we've seen that across Canada, where we have emergency departments in parts of Canada that are closed at nighttime because they don't have any staff to run them. And what has happened in some places is community paramedics have gone in and reopened those departments at nighttime. And so we do have paramedics kind of working in that space of filling a gap in the system. And that's what you'll find, I think, a lot with community paramedicine is it's designed to fix the problems that the system is demonstrating. It's very responsive to system gaps. I don't know if it's a good and a bad thing. It's good because at least the healthcare system, is able to function. It's a bad thing in the sense of a lot of it is um, ad hoc, unplanned, and temporary in nature. Like people see it as this is a solution to keep things open while we try to figure it out. Instead of saying, and what I and a couple of other people are working on is saying, well, why don't we actually embrace that as a piece of paramedic practice now and actually prepare people for it properly, instead of just assuming that we can step into all of these gaps. So again, I think the power of paramedics a lot of the time is you can figure stuff out. Like paramedics, the whole job is about being landed into situations that you're probably not prepared for and figuring out how to actually manage it. So I think paramedics do a good job when they're put in these situations. But I think from a sustainability perspective for the profession, we should probably acknowledge that that is stuff that we're doing and then prepare people better for it. So that's one kind of piece of it. The second piece, I think, around the putting paramedics into some of these roles is we historically have not, North America anyway in particular, we have not embraced the professionalization piece as much as our colleagues have. So we haven't we haven't a kind of a standardized educational piece in North America. We're only just starting to make the move to degree entry to practice now in Canada. It's largely still at diploma level here, and then south of the water in the US, you have generally certificate type courses. So we're lacking that. We don't carry the same level of capital as our colleagues in nursing and medicine when we move into some of these spaces. We don't hold the same types of educational credentials. We're not regulated in the same way as physicians and nurses a lot of the time in Canada. So often in Ontario in particular, paramedics will be sitting at the table and they might be the only one without a degree and they're the only unregulated health profession at the table. And so that puts you in a strange position sometimes when it comes to, like you said, these perspectives of who are these people coming in taking over a role. And I don't think you can claim to be part of that team fully until you're working at the same level, where you have the same type of educational background and you have the same responsibilities to the public from being a registered health professional or whatever. So um, there's definitely points where this conflict arises. I think so far it's been well managed, but it's not. I wouldn't blame nurses in the slightest for looking at some of these community roles and thinking, "Hang on a second," because their job should be to defend nursing roles. The problem becomes when you can't hire enough nurses for those positions. Then
Hmm. Interesting. Uh, there was a question from Tulani.
So mine was not more of a question, but it was more to say maybe community paramedicine should be contextualized based on the country that you're in whenever it's being developed and implemented. I think you've said it more with regards to that. But also, I think you mentioned something now regarding nurses. And we've had in other previous interviews, one of the guys mentioned that in some of the EMS systems that they have, they still have nurses in their ambulance service. And I think that in future, going forward, it needs to be a boundaries, or not boundaries is a bad word, but there needs to be a fine line to define whose role it is, so that to avoid any conflicts that might exist between the paramedics and the nurses, in all to benefit the patients. Because after all, what we do is not for us. Yes, we love treating patients, we love helping patients, but it's more for the patients than than us, our egos.
Yeah, I think that's a good point, Danny. Like, when I started in Ireland in the ambulance service, there were still ambulance nurses. Like, I worked with some ambulance nurses in the Midwest region of Ireland just at the very beginning of my career, and I think the last one retired about a year or two after I started. But historically, Ireland had ambulance drivers and nurses, and these nurses weren't prepared at all, largely, to do the job, because the ambulance driver would do the driver training, and then the nurse was picked kind of at random from a ward, and it was generally some of the more junior nurses that were told, go down to the front of the hospital, there's an ambulance waiting for you. And then these poor people would get dragged out to roll over and ejection MVCs and sudden deaths and stuff, and they weren't prepared for it in the slightest. So that was kind of how it used to be. Then we moved to being paramedics in Ireland, and eventually moved on to regulation and degree entry to practice and this type of stuff. I think it's an evolution piece, and I've worked in systems where nurses are the main pre-hospital provider, like in some of the Scandinavian and Eastern European countries. There's a lot of physician and nurse focused systems, and they work well for what they are. So I think it's just a case, like you said, of there's a contextual piece there. When I worked in the Middle East with Malusi, like the vast majority of our staff were from the Philippines, and most of them were nurses by background, who would then do a 4-week EMT course, kind of based on the US EMT basic curriculum, and then they would work and provide those care. But it becomes hard at that point to say, is this a nurse providing pre-hospital care, or is it an EMT basic? Like they have a 4-year nursing background and 4 weeks of EMT basic. It's likely their nursing background that's actually providing a lot of the background to their care provision. And so, yeah, I just think, we need to, the UK is a good example, I think, of where ambulance services are multidisciplinary. You do have people working for ambulance services in the UK who are not paramedics. You have, occupational therapists, you have pharmacists, you have other members of the healthcare team working to provide it. And I think we probably just need to mature slightly as a discipline to say, the provision of care in this setting can be multidisciplinary, while also at the same time protecting our own identity around what it is that paramedics actually do. But one of the risks to that, I think, is not acknowledging that pre-hospital care is not all lights and sirens and emergencies. It's, if you look at the stats, that doesn't play out. The vast majority of what we do is not emergency in nature, and is instead people trying to get access to the healthcare system. And so you can either embrace that and run with it and say, okay, what paramedics do is some of this stuff, but also is a whole bunch of other stuff that we don't prepare them for very well. Or you can ignore it. But if you ignore it, the risk is that somebody else then will take that piece of the puzzle away from you. So
yeah, I've got another question now. Based on your understanding of the Australian system, this is the last question that focuses on Australia, and I move to Africa now.
Sure.
The intensive care paramedic is a postgraduate diploma that they do in order for them to practice, in order for paramedics to practice and as intensive care paramedics. So do you think that in order for a person to be a community paramedicine, do they need to have intensive care paramedicine, or a normal paramedic with experience can do the job?
The classic researcher response of it depends here.
Yeah. I knew you were going to say that. Actually,
Depends, but
The data.
yeah, no, look, I think that you don't need it as a background to be a good community paramedic, but there are communities who would benefit from you having that skill set and preparation. So like the examples, like I often think about this when it comes to, providing ALS care in urban settings and stuff. Very few urban based intensive care or advanced care paramedics or whatever get to truly practice at their skill set, because it's just very short transport times. You don't have these prolonged interactions with patients and stuff. And again, coming back to, like, if you look at our skill sets, and I say this on a very loose kind of term now, but if you look at the clinical skill set of paramedics internationally, it's all still based on that understanding of what we did in the 70s, that, like, you must be able to, everybody's always caught up in being able to do needle crike or finger crike or RSI, or these things that you're like, these don't actually happen that often in the overall scheme of the provision of care. And instead it's things like people need good options for analgesia, people need good options for seizure management, people need good options for sedation perhaps, or there are other pieces of the skill set that aren't as focused on as much. And if you look at what differentiates an intensive care paramedic or an advanced care paramedic in North America from a kind of entry to practice paramedic skill set, a lot of it is skills that don't get used. Like, and I'm talking just purely from a skill set perspective now, not from an education perspective. But a lot of that skill set sits there redundant. And it's not to suggest we don't need it. There are certainly moments where you will need that skill set. But if you were to look at a return on investment, you'd probably get much more value out of preparing people for things that don't actually require very high clinical preparation from a skill set perspective, and instead give them options and opportunities for referrals, for alternative care pathways for minor illnesses and injuries, for kind of this evidence-based approach to practice. And give an example. We worked on a crewing models report for the Irish regulator a few years ago, and at the time there was a discussion going on about increasing the scope of practice for paramedics in Ireland. And our advice was, instead of just expanding the scope of practice for paramedics so that it becomes very close to the advanced paramedic role in Ireland, which is not the same as the advanced paramedic role in the UK, that it would be probably the best way to do it would be to look at, like, why do people request the ALS support? And if it's, I can tell you, it's probably for things like pain management, seizure management, fluids, the big stuff. Yeah, there'll be some cardiac arrest and trauma management stuff in there. But if you're to look at it, I think, and I don't have the numbers here now, so I'm going to go off the researcher path here and say it's probably things that are relatively easy to add in from a skill set perspective. You would require some additional education and stuff for sure. But rather than expanding scope of practice in a way that isn't targeted, instead use your data. And I say this to people all the time. Paramedic services around the world are some of the most data-rich organizations that exist. And a lot of the time, they just sit on their data and do nothing with it to help themselves. That instead we should look at our data and say, okay, we are calling out advanced life support for these 3 or 4 big ticket items. Those items will now become part of the scope of practice for everybody. And then you reduce your need for ALS for those things, and you can keep your ALS resources then for the more high acuity stuff, or again, redesign service delivery so that these are targeted ALS intercepts or whatever it happens to be. But that realistically, that kind of intensive care scope of practice isn't needed for community paramedicine, but can be very helpful if the community actually would benefit from it. So your intensive care paramedic isn't going to be of benefit to people as a community paramedic because they can do surgical airways or because they can, these trauma skills are not going to be helpful. But the things that they've learned in their additional education around anatomy and stuff will definitely be useful for some of the more primary care intervention pieces that they could support.
Interesting. Right, now let's move to this paper. I enjoyed reading this paper. I think I've mentioned that before.
All the time, the whole time.
I think we're in conflict with Tulani, but I enjoyed this paper. He has papers that he likes. I like this one. I'll tell you why. When you read the paper, it sort of looks at the disadvantaged communities, and it looks at people that had suffered from colonization, segregation because of whatever racism that was there at the time.
Mm-hmm.
Now, one would think that it was written in South Africa for that matter, because it actually fits. Or maybe in Africa, I would say, because even Namibia has suffered the same, Zimbabwe and other countries have suffered the same. But if you look at the countries that were involved, all of them were actually developed countries. And most people are not aware, especially in Africa, that you have people that were also colonized and have suffered due to such. In Canada and Australia and also in New Zealand, there are people that had suffered those issues such that they have illnesses that can't be treated like a person that lives in the city. So there's that separation. That is how I read the paper, and that's how I felt. It is very interesting. Now, if we're talking about the methodology that was used, so this paper is a scoping review. Basically, what happens in a scoping review is you have a period of time from this period until this period, and then you have a specific items that you're looking for, and you go and mine the data. So you go to places like your CINEL, Embase, and Medline, Google Scholar, and other organizations. You do that if you're doing peer-reviewed papers and grey literature, which means that literature that has been not published maybe, or published but it's not peer reviewed. And then you look at whatever substance that you are looking for in those papers using your scope that you've used, and you come up with themes at the end of the day, and then you say this is what you found, and you have a research paper after that. Is there anything you want to add on the methodology, Alan?
No, I guess that there's a very good paper that asks should you do a scoping review or a systematic review, by Munn et al. And because people often get confused as to what the point of a scoping review is. Yeah. And a lot of the time it's to figure out, like, well, what do we know about this thing right now? You're not trying to get is this thing better than this thing type answer. You're just trying to say, what do we know about it? And often a scoping review can provide the foundation for doing a systematic review, in which case you would try to get to a versus B type answer. But yeah, scoping reviews, I think they're actually pretty popular in paramedicine, because a lot of the time I think we're in a really kind of unusual space sometimes as researchers in paramedicine, where most things are not researched yet in our field. And so a scoping review can often be a good way to say, look, what do we know about this already? And perhaps also in other health professions, that we're not narrowing it just to paramedicine. Like, what is known about this topic in nursing and in medicine. And so sometimes we're some of the first people to actually do some of that research in our field. And scoping reviews are a really good way to get an overview of that, to figure out like what the future research projects should be in an area.
Yeah. So the paper that we're looking at is Community Paramedicine Supporting Community Needs, a scoping review. And it is by Tyne Lin, Jennifer Bolster, and Alan Batt. Did I say that right? All of them?
Yeah, so Tyne, it's actually Tyne Markides now. She got married recently. So.
Oh, okay.
Tyne led this review as part of our honours degree in Monash, where I supervised her. And then Jennifer is one of my PhD students in Monash at the moment as well. She's actually based in Tasmania. She's the Director of Clinical Services for Tasmania. And Tyne works for the British Columbia Emergency Health Services out on the west coast of Canada. right now.
Okay. I think I saw something like that on LinkedIn, someone celebrating that they got that position in Tasmania.
Yeah, they're a group who have to be told congratulations quite a lot. Those students, they're all pretty high performers. I have to.
Is it-
Yeah, Melus, before we move on, I know you want to get to the second set of questions. And Alan, this goes back to being as a associate professor and you being supervising students. The question that I want to ask you is with regards to the AI introduction into research. Now, I've got so many questions regarding that, but I want to ask. I recently saw in the news in South Africa where one of the professors at the University of Johannesburg was talking about how AI is not good for students and it affects students' ability to critically think. And students also would take a paper, put it in AI, and summarize that paper. Now, what I want to ask you is, does that affect critical thinking? But also, the question that another one question that I want to ask you is that, and this is from a personal perspective, is that by putting papers onto AI and getting that summary, doesn't it also affect you the ability to understand how to conduct research? Because there's a lot of value by reading on how the scopus, like for now, talking about scoping review paper that you've written. I wouldn't have an idea how to do a scoping review if I never read that. But if I just put it on AI, I get the summary. So do you think there is a role of AI and the challenges that you also have experienced?
He's directing your answer.
No, shut up.
I'm actually really torn on this, Tulani, like, to be honest. So, like, to give an example, this scoping review did use some level of AI. It used machine learning in the software that we use, Covidence, for
Yeah.
it's a systematic review software. Covidence has machine learning built into it, so it'll automatically rank the papers that you find when you're doing your screening. It'll rank them according to what it thinks are the most relevant. Does a pretty good job at that. Like, when you get to the end of your screening in Covidence, you're largely rejecting papers because they're not at all relevant to your question. And it seems to front end a lot of the papers that are relevant. So there's definitely, I have this joke that, like, I try not to use AI in my research work because I did a PhD that didn't involve AI in any shape or form. I got a lot of value out of, there's an old Irish saying called, and it says that you can't plow a field by turning it over in your mind. That, you actually have to do the work.
Do it, yeah.
You can think about plowing the field all you want.
Love
The
it.
field isn't going to get plowed.
Yeah, love it.
And so the doing of the work is actually really important in a PhD program for me. That, like, you should be struggling with summarizing things in your head. You should be struggling with trying to make connections with things, because that struggle is actually where the learning happens. Like, people are afraid of being uncomfortable in learning these days, where they want summaries of things, and people want podcasts, not this kind of podcast, no, but podcasts that, like, that summarize papers for them so they don't have to read them. And like you said, I think a lot of the value is in actually doing the work. I'm a big fan of your podcast, guys. No, but seriously, like, the reality is that you can't shortcut your way through a PhD. And if you do, it'll be obvious at the end of it that you're not prepared to be an independent researcher, that you're not prepared to think about things in the way that a PhD actually requires you to think about things.
Yeah.
So I'm torn in that I think AI is actually extremely useful in the sense of, the machine learning type stuff. One of the pieces I'm really interested in, and there's people working on it, is having AI or some kind of machine learning program as a second reviewer, for example, when you're screening papers, that you wouldn't need a second human to be able to screen, because screening is the worst thing in the world, where you're just reading abstracts and saying yes or no. And, like, I've done some reviews that have had 15,000 of those that you needed to screen, and that's weeks and weeks of going in, several hours a week of yes, no, yes, no, yes, no. If you were able to do that, and machine learning was able to work alongside you and predict whether something was in or out based on, parameters that you set for it, then I think that would reduce the workload. Like what's definitely happened since 20 years ago compared to now is there is so much information out there. Like there's, hundreds and thousands of papers published every week that it becomes really difficult to stay on top of things. And a review 20 years ago in a PhD might have had, a small amount of papers. Now today it's going to have thousands of papers at the beginning before screening. And so the demand on people from that perspective is extremely high. And it leads to, I often thought before I got into research that like reviews are easy. You just kind of ask a question and go and find the papers and then summarize them. I found that on average, a scoping review takes somewhere between 12 and 18 months to do properly. Like you're talking several months just to nail down your search strategy. Never mind doing the searches and actually extracting the data and all that kind of stuff. So I think there's a definite benefit to AI in research. There are huge risks too. There's been a number of cases of, I don't know if you saw, there was some law professor recently who used AI to come up with some argument in court, and it hallucinated a bunch of case law.
That didn't exist.
I
think
play
you're
along
supposed to
with
double
I play
check
around
it,
with ChatGPT quite a bit, and it hallucinates references all
It
the time.
does.
Like it just
It
makes them up, and when you
does.
push it on it, it'll tell you, "Oh yeah, sorry, I made that one up."
Too late now.
Well, why? It was easier not to make it up, but it does that. So yeah, in general, I'm wary of it for production of research stuff. It may have some value in summarizing things for people, but again, I think when you shortcut too much of this stuff, you end up in a situation where you're not able to see the connections between things because you haven't put the hard work in. Like I remember in my PhD reading all of these different theories, and reading 4 or 5 papers on each theory, and at the end of the 5th paper going, nah, it's not this. And that's 5 papers worth of reading. Now you could say that that's very inefficient use of your time. If you do that 20 times, you've read 20 theories and you haven't picked any of them. But I still have an understanding of how those theories work now, and I might come back to one of them at some point in a paper. It's very difficult to do that, I think, when you haven't actually put the the kind of sweat equity in, when you haven't actually worked at the thing.
The work.
So I feel like I'm going to give you an it depends answer here again, but it's I think it can be very good, and I'm excited to see where some of the AI stuff goes. I'm very cautious about using it, and the furthest I would go with using it in writing a paper is to tell it to give an outline of what a paper should have in it on a particular topic, and then the rest of it would be written. But to be honest, I've never used AI in publication. I would use that as like testing around to see like, okay, is it capable of doing this? I only did one during the week where I asked it to give me an outline of a paper, and then I asked for 15 references related to this topic, and it hallucinated 6 of them. And so I think you need to. There's a lot of critical thinking needed when you engage with using AI in some of this stuff.
Yeah.
When you were talking, sort of like you were talking to me about what I'm going through now. It's like a support group, the struggles that I'm having. And I think you mentioned that you have to put in the work. Some of the stuff I'd read multiple papers, but it really makes sense. I'm like, at the end, it's not making sense.
Yeah.
Or it's not relevant to me. But I'm like, so much time that was spent doing this. But I think there is value of AI, just that people need to use it responsibly in order to make sure that they do the work, they're able to understand the work.
Absolutely.
And also they're able to critically, it helps to shape the way you understand. I mean, just to share my experience is that one of the biggest hurdles, I think we chatted before we started recording, I said to you guys, I was never a qualitative researcher, never at all. And I hope my supervisor won't watch this. I was never.
I'll get them.
And one of them said to me, it's going to be uncomfortable. You have to read those transcripts and you have to do thematic analysis. There's no shortcut, which is what you've said. There's no shortcut. And I went and did it over and over again. I felt like I was going crazy. But at the end, I got to understand how to
Mhm.
do thematic analysis and how to produce meaningful themes and quotations based on analyzing the data, and I'm able to do that part. And if you put all that into I don't think it will produce
Well, yeah, you went and plowed the
human
field,
research.
Lanny. Like
Yeah, yeah.
you did the work, and it is I feel like a real like old man yells at cloud kind of thing when I'm like, you got to put the work in. There's no shortcutting things, and it's really like kids these days can't put the work in. But the reality is that I think AI has a huge opportunity in PhD research and research in general to take away the boring, menial stuff of like you're not developing as a researcher when you're screening titles. Like it's just it's an administrative burden that you need to do. I think if we could take that stuff away and give people back time to actually grapple with, conceptual and theoretical problems, I think that would be far more productive. So I guess I don't want to come across as someone who's anti AI. I think there are points where it's useful and there are points where we shouldn't try to get it to do the job, because the work should be done by a human, because that's where they develop. I do some research in health professions education, and there's this concept of the zone of proximal development, and it's that point where you feel slightly uncomfortable when you're learning something new, and it's because that's the growth area. Like you shouldn't be thrown in the deep end of the pool and everyone says, well, you got to figure out how to swim. You should know that someone is there to help you, like a supervisor, figure this out. But you should be left to be a bit uncomfortable, because like you said, doing thematic analysis for the first time or whatever, there's an uncomfortableness in it where you're like, I'm not quite sure if this is right. But as you work your way through it, you start to get a bit more comfortable with it, and at the end of it, you are comfortable with it. You're like, yeah, I did a thematic analysis, I followed the instructions, I checked in with my supervisor, and now I know how to do it.
Yeah.
That's learning. Like there's growth there. So I think being uncomfortable in a PhD or in any type of research learning is a good thing, as long as you're not abandoned, and that's the key.
I've thought of so many times to do that.
I know once we dive into the research topic, we'll talk and we won't stop. But I want us to come back to community paramedicine. There is there's something that I want to say. I want to say that in South Africa, or in Africa, we have actually even in Kenya, we have emergency medical care services, which is what the ambulance services is. There was a time where it was called a lot in academia and universities, they'll say pre-hospital care, and so there's been a change in the language much. But the ambulance services, especially the provincial ones, they are still called emergency medical services. So they focus mainly in emergencies, and we are known in South Africa with having a lot of trauma of some sort, car accidents, sometimes gunshots. And what they don't talk about a lot is a lot of other conditions that we have, like your HIV, AIDS related conditions, cancer, and all those conditions, which are patients that you find at home. And sometimes they don't want to go to hospital because they don't have transport to come back. Adding to that, I thought that this paper relates because you have patients that will live in 2 hours away from hospital, and going there, they have to wait. Going to hospital may have to wait for a bus that comes once a week on Thursday that takes them to the city, and then comes back afterwards. It's something that happens, something that is well known. But I do think that there is room for community paramedicine even in the context of Africa. But now, since this paper only looks at the developed world, do you think that the tool that has been developed can work and be translated to the low and middle income countries?
Yes. Look, I didn't give it depends answer. I think that the tool is definitely. So I know we did the scoping review that looked at social needs, and community needs in general, but largely focused on that health social continuum and the social foundation for a lot of the health issues that people present with. That one of the biggest things we're facing in a lot of the high income countries is older adults who keep reoccurring their presentations to ambulance services, paramedic services, or emergency departments, largely because they're socially isolated. They live in a rural setting, perhaps. They're of an age where a lot of their friend group has died or is in, long-term care facilities and stuff like that. And so their isolation and loneliness is actually leading to a lot of their health system demand. And you can't prescribe your way out of that. I mean, you can do what's called social prescribing, where we're just launching a big initiative on that in Canada right now, where we're going to say, paramedics have a bigger role to play in things like social isolation, in things like redirecting people to food banks, to, maybe your job as a paramedic is to sit down and chat with someone and find out they really like baking, but since they're arthritis, they can't put the trays in and out of the oven safely. So you get them either someone to help with that, or you get them to go to a baking class that's designed for older adults, or that there probably is a role for paramedics to play in some of that stuff. So that's one kind of thing that came out of that that scoping review, is we probably need to embrace that side of the job a bit more. I get that it's not as sexy as the trauma, the shootings, the serious car accidents and stuff like that, but I think that's again a myopic 1970s perspective on what paramedics did. And like I said, there is absolutely a need for people to be able to do that side of the job, but when that's 5% of your workload, you probably shouldn't hang your entire education, training, and service delivery on that 5%. You should probably address the other 95 a bit better. So there's that. Then that led to this community paramedic needs assessment tool. The one thing I will say about the scoping review is we didn't focus on high income countries. It just so happens that that's where the evidence is published from. And that is definitely a limitation of the review. And we would say, but that's not even about our review, let's be honest, Malusi. Like there is, and this has come up, I'm a deputy editor for Paramedicine, the journal, that has come up on our leadership table and at our editorial board level as well, that we have a severe underrepresentation of low and middle income country authors and issues in a lot of our journals internationally because of systemic barriers. Like it comes down to, for example, you don't have the same level of funding, you don't have the same level of support. English is not some people's first language. There's hurdle after hurdle here to try and publish the research from low and middle income countries in journals where others around the world can read it. So I think we've acknowledged that at that level at the journal, to say we probably need to do something a bit better about this, and we are making steps towards that. I would love to have seen more papers from Africa, Southeast Asia and stuff in our scoping review. They just they weren't there, and that's a problem. Saying that led to the Community Paramedic Needs Assessment Tool, another project led by Tyne as part of her honours, and actually Healthcare Excellence Canada funded the development of that tool, and they are now also funding the social prescribing initiative that we're just launching. But that needs assessment tool, despite it being based on a lot of what we call like Western or high income country evidence, we came into that tool with a very deliberate perspective on equity. That the systems in Canada, realistically, where the tool was built, the health system in Canada is rooted in colonialism and is rooted in inequities for certain populations. The health system has mistreated Indigenous people in Canada, for example, for the last 40, 50 years. There's a mistrust of the health system amongst those populations. And so our kind of mandate and our thinking at the very beginning of designing that tool was, how do we help community paramedic programs design themselves in such a way that they start to undo some of these inequities, or they start to deliberately address some of those? So that's the piece I think that you can translate to any country in Africa or any country in Southeast Asia, is to say, okay, the exact terms we use are probably very Canadian, but the concept of truth and reconciliation, decolonization, promoting equity, working with communities to design their programs. All of those are principles-based approaches that can be used anywhere, I think. I would love to see this tool used in Africa. And what I would love to see is we used it and actually we have problems with these 5 questions. They don't translate very well to our context. And here are 5 questions that would work better, because that's ideal then. That helps you to come up with things. And I guess all of this came from the fact that 2017, the CSA group in Canada, the Canadian Standards Association group, produced a standard on developing community paramedic programs. So there's a standard out there that you can access that says, if you're going to design a community paramedic program, follow these steps. One of the steps said, do a needs assessment. And there was kind of no more information given. And since the publication of that document, myself and Brendan Shannon in particular have come across this issue so many times when we're talking to people running community paramedic programs. They would say, yeah, there was no, like, I couldn't find a needs assessment tool to use, so we just kind of looked online and we found something and we used that. And this was for years. Me and Brendan in a number of publications over the past few years have said we should probably design a needs assessment tool, hoping probably that someone else would do it. But we eventually ended up at the point where we were like, okay, we got to put our money where our mouths are here and build a needs assessment tool. And so we developed the needs assessment tool. So that's really important, because a lot of the time, and I think this requires a change in how we view community paramedicine. It's probably a really good thing for Africa to say, okay, we have this tool now. We're just starting to look at community paramedicine, because historically community paramedic programs in North America were designed based on resource protection. So it was the ambulance service or the paramedic service was saying, we're sending too many ambulances to people with diabetes who then refuse care and stay at home. Let's set up a program, a community paramedic program that addresses the healthcare needs of frequent service users who are diabetic. And so it was built from the services perspective to protect their assets, to stop sending ambulances to calls that don't result in a transport. What this community paramedic needs assessment tool says is we should be flipping that on its head now and designing community paramedic programs based on what the community wants to be addressed. So if we work with communities to co-create these programs, we could end up with programs that we've never seen before, because we're not the ones actually deciding on the program anymore. It's the community telling us. And I think that's a huge shift, because if the health system is left in charge of all of these things going forward, you're really only reinforcing the same structures that you had in the system around, colonialism, and I guess in North America in particular, like white settler perspectives on what healthcare is. And that piece wouldn't translate very well to Africa for sure. There are, traditional healers and all this kind of stuff that do need to be built into these programs. Those perspectives are important to certain communities. And if you're going to design a program for them, then that should probably be included. Like it seems very logical when you say it like this, but the reality is that up to this point, we've never really built community paramedic programs in that way. We've never started with what the community wants. We've always started with what we're trying to protect, which is generally sending ambulances to calls. So I would be very interested, and I would actually encourage people to try and use the CPNAT in different contexts in Africa. And then I would really encourage them to figure out how can it be improved for that particular setting. Because it's open access, it's Creative Commons, it's there to be modified and adapted. People should do that.
Fascinating.
It is interesting. I think I have 2 questions. Sorry, Malusi.
Yeah.
And I know we're running out of time. And I think, Alan, I just kind of want you to touch on, and I know, the community paramedicine is sort of like filling the gap, as you don't want to send you an ambulance again, especially if you've been calling 5-4 times, let someone just come into your household and check on you. But let's chat about what's happening in Canada and what they're doing and what the training is currently in place. Like, what sort of modules are you focusing on? Let's say, for instance, the ones that already have a base degree. sort of like what top up, I don't know, modules are you doing just to make sure that, even though you don't have the prescribing right, because I think I have another question on social prescribing needs.
Yeah.
But, sort of like what training are you adding on top of that just to make sure that, you are sort of suitable in that sense, and that, you can cater for the people in need, and that you're not a critical care paramedic, but you're a community care paramedic.
Mhm.
What sort of like skills do you need in order for you just to meet those requirements?
Yeah, that's. I wish there was an easy answer to this one, Elias, but the reality is that community paramedicine education in Canada is actually not very well developed. A lot of it is in-house, service-specific, which isn't a bad thing. Like when you think about the fact that almost every community paramedic program in Canada is slightly different, it becomes a bit of a challenge to design a program of education then that would allow people to work in any of those programs. So there's that challenge, first of all, of we haven't really standardized what a community paramedic is because the programs themselves are so different. So some programs are doing a lot of like virtual care, telehealth, remote patient monitoring. Other programs are doing clinic-based assessments in like socially marginalized populations in like social housing. They do a clinic. Others are doing home visits. Others are working in long-term care facilities. Others are part of a palliative care team in the community. So community paramedicine isn't it's not like a thing that exists that you can look at. It's a whole bunch of different things, and that's a challenge for educators. So right now there's only a handful of education programs in Canada aimed at community paramedicine. There are more in development, and our eventual plan, we released a career framework for paramedics in Canada last May, and I know you had a podcast where you looked at the UK model. We have a similar model in Canada, except it has a fifth pathway on policy and strategy, which the UK model didn't have. But from a clinical perspective, we are kind of suggesting that piece around, paramedic, specialist paramedic, paramedic practitioner, that climb up of clinical levels. And our specialist piece is really aimed at specialized context. So we're saying that, community paramedicine is a specialist context of practice. You need to be a paramedic, first of all, to work in that space, but then you need additional skills and education to be able to do it properly. So we would call it specialized. The same way that someone who's working on, as a tactical paramedic, or someone who's working as a search and rescue paramedic, or these are all specialized contexts and require additional preparation. So we've signaled our intent to move in that direction. That would mean community paramedicine needs to move to some kind of postgraduate qualification in the near future in Canada. And in general, people are embracing that. And there are some programs that exist in Canada right now for it. So I think that's one big thing to acknowledge, that, right now we have community paramedics out there doing the job who are amazing at the job. And I'm not saying this, it's because we've done, there are people who have done research, and patients themselves love the service. Family members love the service. Community paramedics themselves love working in that space. So it works. But have we prepared them in the best way to do that as a system? No, I don't think we have. So I think that's one of the big things that we need to acknowledge here, is that, there are challenges with the current system around that. And hopefully that will start to evolve a bit more over the next few years, now that we've kind of laid out that pathway of here's what this needs to start looking like.
Yeah. Look, this is a very fascinating topic, and there's a lot that we could ask around this topic. But in closing, I want African paramedics and African health institutions, the policymakers, academic institutions, including even the councils, to think about this. Imagine those patients that are in, let's say, in Paraguana Hospital on Friday. It's always packed. There's hundreds of patients. They are not going to be seen. They're going to be seen on Sunday morning. They arrive on Friday. Or in King Edward Hospital, or in Eddington Hospital in Durban. Imagine there's always influx of people. Imagine if those people were, maybe even a quarter of them were treated at home, they were given an IV possibly for dextrose, if they've got the sugar level, and then they're left at home, that would reduce the load for the hospitals. And if these are the government institutions, it means that the load is less. Patients that need to be there are there and they are treated. I do think that there is room for this. I do think that we do need to look into it and see if we can't implement it. I know things take forever in our parts of the world, but I do think that we have to try and see if we can look into this community paramedics and see if we can add value. In closing, Associate Professor Alan Batt, what do you have to say?
Look, these things take time, I think, again, and they evolve. Look at community paramedicine in Canada from where it started to where it is now. It's unrecognizable. But what has been recognized over time, and I would say this, if you're going to start trying to bring this into Africa, is plan it out from the beginning in a way that you can prove its impact. And that's been our biggest struggle in Canada in particular, is proving the impact of community paramedicine. And I don't just mean, people have done the work, Gina Agarwal and others have done the work on community paramedicine saves money in the system. So the economic argument is there. Community paramedic works for patients. They appreciate the connection and the relationship with their provider. So it works from a patient-reported perspective. Community paramedics themselves love doing the job, and they will say that. So it works from the provider perspective. Community paramedicine reduces emergency department attendance, reduces calls, all of that. So the argument is there from the service side. But we didn't have all that planned out from the beginning. These are all pieces that happened along the way. I think if you're going to bring it in, have a very clear plan on, here's how we're going to measure success, with maybe a small, pilot scheme or whatever, and then use that to get policymakers and others who value different things. Some will value an economic argument, others will value a ED reduction argument. Depending on who you're talking to about it, they're going to have different things that they want to see. And if you build it in a way that you can show that stuff from the beginning, you'll have a way easier pathway forward.
Yeah. Is there anything else you want to add, Jens?
No, very impactful conversation. I absolutely enjoyed it. I think there should be a second segment to it. And I think I actually have more questions that I've not even had the chance to ask. But yeah, Tulani.
Yeah, I was gonna complain. Like, where do we complain? It was never enough time because there was so much to unpack. But I hope that people can read the work that you've done, because you've published a lot in the space. And to get that information and also to drive policies. I mean, this is interesting stuff. I mean, one of the reasons why we do research, we hope to change the society, the community, to impact on policymakers. So, yeah, and thanks for doing the work. I mean, it means a lot to the community to change the future of paramedics.
Yeah, thanks, Delaney. And I'll just one last plug for. We literally just published a paper this week on paramedics and policy. Jen Bolster led that, a commentary piece to say we're actually not good as a profession at this. We're good at doing the research and proving what we do works. We're really bad at getting it in front of people who make decisions at a government level around funding and around health service design and stuff. And as a profession, I think if we want to have the impact that we think we want, we probably need to be sitting at those, we call them like the big boy tables, or like the adult table, instead of sitting at the kids table. That takes a very deliberate decision by the profession to say, putting people into strategy and policy positions is a priority for our profession, and we should develop those people from within. Not just hope that they'll get there, but actually deliberately engage in getting our researchers and others into the spaces that make decisions around funding and service design. So that then the system can move forward. And Jen's PhD is focusing on that piece, that we're really good at like community paramedicine, we're really good at adapting to communities' needs, but often one level above us, there's a policy that prevents us from really doing that properly. And so we all are busy doing the work, but the reality is that above us, the layers are designed to not allow us to do that work because of historical funding decisions or whatever. So you'll never truly fix things until you fix it at a higher level from a policy perspective.
Associate Professor Alan Batt, we highly appreciate your time. You can find this gentleman on his website. Actually, there's a link. You Google Alan Batt, and then you'll find a lot of links there. He's had, I was trying to count the publications there. I think it's like close to 100 or more than 100 in papers and commenters and whatever stuff. He is working a lot. I wonder where does he find the time to do all that. But we respect you. And I noticed also that you also won an award for being a superb supervisor too in one of the universities. I don't know. You're just always working, I suppose. Thank you very much. We thank you for your time and we highly appreciate you. Thank you.
Thanks, guys. It was a lot of fun.